Mr. D is a 59-year-old male. He presented 3 weeks ago complaining of allergies causing a lump of phlegm in his throat. You did start him on Flonase and had him come back in 3 weeks, and he is back today. He returns complaining of dysphagia. He has some difficulty with swallowing meat. It's getting stuck in his throat. He is not having any issues with fluids. Subjectively, he has a social history of being an incarcerated male with a significant alcohol intake over many years. He is a 45-year pack smoker. Medical history involves a normal EGD about 10 years ago per patient report. For chronic GERD, he does have type 2 diabetes, hypertension, and BPH. He takes metformin, lisinopril, Zantac, and Hytrin daily. His surgical history includes a history of an appendectomy at age 14 and multiple gunshot wounds to the abdomen at age 29. Under review of systems, subjectively, he does admit that he has some fatigue. He denies nausea, vomiting, diarrhea, constipation. States his GERD flares up 2 to 3 times per week. He reports he has been losing weight. Objectively, his weight does not show that. It shows he's up 1 pound at 168 from his last visit of 169. His height is 5'10". His vital signs today are stable. He is alert and in no acute distress. His head, eyes, ears, nose, and throat, unremarkable. Lungs clear. Heart rate, regular. Rhythm, no murmur, rubs, or gallops. Abdomen is soft, non-tender. Bowel sounds are present ×4. Recent testing includes an A1C of 6.4% 2 months ago. His blood work at that time showed a normal chemistry panel, including liver and kidney function tests. Under differential diagnosis, number 1 is GERD. Is likely due to history of GERD, the sensation of the globus sensation in his throat, heartburn, and dysphagia. No additional testing is needed at this time, as a proton pump inhibitor could be started, and if the initial therapy is effective, then no additional testing is needed, according to Ferries. If this is not effective, and if we did start that, we would stop the Zantac. If that's not effective, then we consider an upper GI endoscopy to evaluate for signs of Barrett's esophagus or tissue damage. Number 2 differential is esophageal tumor due to his report of weight loss and dysphagia that's occurring with solid foods. Ferries 2015 states that dysphagia initially with esophageal tumor begins with solid foods and progresses to liquids as the disease progresses. This also is somewhat likely due to his history of alcohol abuse, which is an etiology for esophageal tumor. This is less likely due to the absence of hoarseness, dry cough, and cervical adenopathy. Hiatal hernia is the 3rd differential. This is due to the presence of indigestion and dysphagia. The workup would include an upper GI with barium contrast swallow series to define the anatomic abnormality, or an upper GI endoscopy, as well as an abdominal ultrasound to evaluate for an esophageal diameter of more than or equal to 18 millimeters, which would suggest a sliding hiatal hernia. All of this information is referenced in Ferries 2015. Questions for the preceptor would involve: at what point is an invasive procedure such as an endoscopy preferred over non-invasive such as an ultrasound? Further learning would include learning to differentiate disorders of the esophagus versus gastric disorders such as peptic ulcer disease. Thank you.